Now starting. All attendees are in listen-only mode.
Dr. Emily here. Welcome to another EBFA Thursdays webinar series. Again, we are doing this the first Thursday of every month at 8 o'clock Eastern Standard Time. If you happen to miss any webinar for whatever reason, please know that they are all archived and kept on the EBFA website, which is ebfafitness.com, and then there is a tab for the webinars. If at any time you want any of the PowerPoints to any of the webinars, please do not hesitate to reach out. You can email us at education@ebfafitness.com. After today's webinar, if you have any questions that you want us to go over at the end, please type them in and we will go through those after I do the presentation. So, as we get started, this is isolated gastroc stretching adequate for plantar fasciitis? I think this is an awesome topic for fitness professionals and movement specialists because they and you are bound to see a patient who's experiencing chronic or acute plantar fasciitis. So, this is one of the most common complaints we see in a podiatrist's office, with over 10% of adults experiencing plantar fasciitis. This means that you, as a fitness and movement specialist or a coach, are bound to have a client or athlete who is suffering with this condition. The way that this condition is treated in a podiatrist's office is very narrowly treated as the foot and ankle as an isolated unit. And as a podiatrist, but as a movement specialist, I have a big issue with treating plantar fasciitis from an isolated, narrow standpoint. So as we see through the webinar, we'll see how we must do functional assessments and a little bit more proximal assessments to really look at what is the cause of this patient, client, or athlete's plantar fasciitis. So we take a lot of steps in a day, up to 5,000, 8,000 steps a day. The stress from standing, right? We have that eccentric contraction of our soleus when we stand in place. So both of these, whether it's the contraction to control ground reaction forces with every step, or if you are statically standing and your soleus is firing eccentrically nonstop, both of these put your foot at risk for dysfunction, decreased ankle joint range of motion, and eventually plantar fasciitis. So, what is the plantar fascia? So, plantar fascia, a little bit of a misnomer sometimes in the fitness industry and how I hear fitness professionals refer to this, but anatomically, plantar fascia is connective tissue which starts on the plantar aspect of your heel. So, right about there, plantar, it's the medial calcaneal tubercle is where it originates, and then you can see it extends into the middle of the foot, and then it slips or it branches off into these 5 slips into each of the toes, and it actually attaches to the digit, all 5 digits, and plays a very important role in stabilizing those metatarsal phalangeal joints, or the MPJs, right, especially our big toe joint. Okay, when we walk, our plantar fascia actually plays a role in creating and helping to supinate our foot and make it into a rigid lever. This is called the windlass mechanism, and windlass mechanism is critical for flex or bend our toes. Especially how you bend that may actually cause symptoms for your clients or athletes. So there was a study done in 2011 by Patel that saw that 57% of patients suffering from plantar fasciitis had isolated gastrocnemius tightness. So does this necessarily mean that we should be stretching only the gastrocnemius? Or again, should we be looking at what is influencing the tightness in that muscle? So, what is plantar fasciitis? Plantar fasciitis, again, is that band running on the bottom of the foot, starting from the heel and inserting distally into all 5 digits, right? This is a painful, inflammatory condition that typically causes pain first step in the morning or pain after a period of rest. Patients or clients will often complain of pain right where that plantar fascia inserts on the plantar aspect of your heel, or they will experience plantar fasciitis in the middle of their fascial band. So if you have a client and you want to assess their plantar fascia, or you want to palpate your own plantar fascia, the best way to tighten it and make it easier to palpate is by dorsiflexing your hallux, or bending your big toe back, and then you will be able to palpate the bottom of your foot, and you will probably be able to feel a nice tight band of that fascia in the bottom of your arch. So we have a patient or a client or an athlete experiencing acute, right, early onset plantar fasciitis. They're having that pain first step in the morning. They complain after they sit for a while and then start walking. They get this sharp pain in their heel. Right, we start treating them with ice, orthotics, anti-inflammatories, and then one of the most common recommendations by a podiatrist is stretch your calves and stretch your plantar fascia. So again, studies have shown that there's an association between decreased ankle joint range of motion and plantar fasciitis. Okay, so does this mean that it is indicated and effective to recommend isolated posterior group stretching or gastrocnemius stretching, right? Or should we be actually evaluating our clients, patients, and athletes for what is the actual cause of that decreased ankle joint range of motion, right? So are we merely treating a symptom, that being the plantar fasciitis, or is it more functional and effective for us to actually find the cause of that decreased ankle joint range of motion? So we must look beyond the foot, right? We consider the human body as one single interconnected unit, right? Our foot is connected to our knee, our hip, our lower back. Every joint influences a joint which is proximal and distal to it. So we must ask ourselves, does our client or patient have decreased ankle joint range of motion due to a tight gastrocnemius or tight soleus, or perhaps there is a bony block present? Is it a structural tightness? Or does this client or patient have a muscle imbalance that is more proximal, i.e. in the hip, which is actually leading to the tight calves and decreased ankle joint range of motion? So every client or patient who comes in and has plantar fasciitis must start with an open chain and closed chain ankle assessment. On the bottom, I am doing a little assessment to see if it is their gastroc or their soleus which is causing the tightness, right? So you're putting the ankle into what is called subtalar joint neutral, dorsiflexing the foot to maximum ankle joint dorsiflexion. Hold that ankle joint dorsiflexion, have the client bend their knee, and if you get an increase in ankle joint range of motion, that will indicate that it is their gastrocnemius that is tight, right? So again, if you hold the leg or the ankle at maximum dorsiflexion, bend the knee, you get an increase in ankle joint range of motion, that is their gastrocnemius that is tight. If you get no increase in ankle joint range of motion, it is then more of a soleus influence on that ankle hypomobility. On the top, I am doing a functional closed chain ankle assessment. We are trying to have the client bring the knee as close to the wall as possible, and you want to keep that heel down. So have the client keep moving forward until you can see how much tibial translation they can get. So that would be a closed chain ankle joint range of motion. Once you determine what the degree of ankle joint range of motion is, you need to consider other possible causes for decreased ankle joint range of motion. You must always have on the back of your mind that this client or athlete could possibly have what is called a bony block. Especially if you work with dancers and runners, they can get this shift in the talus bone within the ankle joint. So this talus bone will shift forward. Then when the foot dorsiflexes, they will actually hit the talus on the edge of the tibia, which blocks and limits their ankle joint range of motion. Again, this is called a bony block. You get that anterior or forward shift of the talus bone within the ankle joint. So when the client or athlete goes to dorsiflex the ankle, they will hit the tibia bone against the talus bone. And this will mimic decreased ankle joint range of motion, which is often treated by stretching the calves, and this is not the appropriate treatment or recommendation for that client. Okay, what's interesting about the talus bone is that it actually does not have any muscle or tendon attachments. So for those who do a lot of repetitive movements such as dance and running, it is very easy to have that bone shift forward within that ankle joint. Okay, second consideration that you must always have for a client who has decreased ankle joint range of motion is, would this possibly be structural? In the case of a structural decreased ankle joint range of motion, as in a cavus or high arch foot, this means that you could be stretching and stretching and stretching those calves, and they will not increase any flexibility within that muscle group just because of the structural nature of that tendon and of that foot. We will see that the recommended treatment for that client and that athlete is not stretching. Statically stretching in that client could increase the risk of Achilles tendonitis and micro tears within the tendon and the plantar fascia. So that client, the recommendation would be myofascial release. Once we assess ankle joint, determine ankle joint range of motion. Is it the gastroc or the soleus that is tight? What is their functional ankle joint range of motion? Right? Have we ruled out a bony block or a structural reason for decreased ankle joint range of motion? We must then go proximal. So we must assess every single client with plantar fasciitis and decreased ankle range of motion for what's going on in their hips. Do they have an anterior pelvic tilt, like this top picture? Is that anterior pelvic tilt secondary to tight hip flexors? So then you want to do a Thomas test, which is the image on the bottom, where you are assessing, is it overactive and tight hip flexors, which are pulling that pelvis forward into that anterior position, which you can see the picture on the right. That anterior position is putting a strain and a pull on that posterior muscle group, which would be the hamstrings. And then myofascially, our hamstrings are connected to our gastroc and our soleus. And then our gastroc and soleus are myofascially connected to the plantar fascia on the bottom of the foot. In that patient, it would be much more effective to instead try and reposition that anterior pelvic tilt by stretching and deactivating the hip flexors, which would then cause a relaxation of the hamstrings, the gastroc, the soleus, and the plantar fascia on the bottom of the foot. So, highly recommended functional approaches to your patients and clients with plantar fasciitis. Again, every client athlete with plantar fasciitis, you must do that ankle joint assessment. If it is noted that they have a decreased ankle joint range of motion, you then have to go proximal and look at the flexibility and position of their pelvis. If we do see that there is a bony block present, you want to address this by doing what is called a posterior glide. I like doing a passive posterior glide, and I teach this to fitness professionals so that you are not manipulating your client or athlete's talus, but you are allowing them to passively push their talus back into their ankle joint. There are physical therapists and manual therapists who can do a abrupt posterior glide of the talus, but again, I do not recommend doing this unless you are trained or licensed to do this technique. In the client that you see that they have decreased ankle joint range of motion, they stand a lot, their job requires them to be standing on their feet all day, and they have active trigger points within their soleus muscle, then I recommend doing trigger point release. Remember that eccentric contractions, just like the ones that are firing in the soleus to keep us standing, create adhesions at a higher rate than concentric contractions. So any client who is suffering from plantar fasciitis and their job requires them to stand long hours, I would assess their soleus for trigger points and integrate trigger point release into their program, and they will probably get much better results than doing an isolated posterior group stretch. I also recommend doing the trigger point release in the clients who have a structurally high arched foot, just like in the previous picture, that high arched foot, that they have innately tight posterior muscle group. So again, statically stretching in that foot type that is suffering from plantar fasciitis, you could be doing more harm than good by micro tearing that Achilles tendon. So then they're not just dealing with plantar fasciitis, they're dealing with acute tendinitis. So again, myofascial release in both that high arch foot type and in those with soleus trigger points. Last one is if you see any proximal influence, that anterior pelvic tilt position, you see an overactive hip flexor, elongation of the hamstrings, I highly, highly recommend integrating hip flexor stretches to try and reposition that pelvis into a neutral alignment and trying to get some laxity into the hamstrings, gastroc, soleus, and plantar fascia. For all hip flexor stretches, I recommend doing all 4 hip flexors, which includes your rectus femoris, your psoas muscle in the center, your TFL, the picture on the right, and your iliacus. Right, so we're getting rectus femoris, psoas, iliacus, and TFL. So all 4 of our hip flexor muscles, we're stretching effectively, holding each of those static stretches for 30 seconds, rest, and repeat 5 times. So if you guys have any questions, please type them in. We'll go over them. See, I think we have a question. Okay. Again, any questions, please do let me know. We have upcoming workshops, always having our barefoot training specialists. We are in Chicago, Boston, New York, and Miami. Again, May and June coming up. Please sign up. And we have a brand new exciting course which is called Bells and Bare Feet, where we're going into the why behind barefoot kettlebell training. It's going to be a very exciting course. First one is in New York City, and then we will definitely be having more. So Eli has a question. Did not mean to get out of that. How can I train my client with a bony block to tape properly? So I'm going to show you that picture. All right, so here is the tape. So you can see that the tape is going kind of across the anterior and an anterior posterior direction, trying to follow kind of the natural pull of the talus. So if you did it just this way, right, you're not going to get the talus. You want to actually consider that the talus is kind of forms a joint with the calcaneus, so your pressure through the tape is going to go from anterior proximal to plantar distal in this direction. Okay. There's also a great stretch where you can take a resistor band and kind of take the loop of the resistor band, tie it on a fixed object, and then place the resistor band around the anterior aspect of your client's ankle and then have them squat that way so they're functionally moving the ankle joint with that posterior force from the resistor band. I also recommend that technique for repositioning. All right. So Jennifer has a question. Can you explain more about the Thomas test for an anterior pelvic tilt? So the Thomas test was right here. So the way that you want to start the Thomas test is have the patient or client take both knees. So they're kind of grabbing both knees to their chest, and then they're going to keep one knee to the chest and drop the opposite leg to the floor. And what you're looking for is, if in this client in the picture, if that left hip is popping up, that is going to signify tight hip flexors on the left side. So again, client is starting with both knees in the chest. Keep the right knee to the chest. Drop the left leg down. If you see that the femur angle is kind of angulated up because they have the tight hip flexors, you want to assess both sides. That would be a positive Thomas test. You're very welcome, Eli, about the band. Again, I do that a lot with dancers. So the posterior glide that Eli was asking about, again, I do that with dancers because this tape can be very irritating to an athlete, especially if they're doing a lot of repetitions. So I do the band work and kind of reposition before every workout or before the dancer trains, and then they reposition it. And then I actually do this posterior manual therapy. I do that on patients in the office, but it's difficult to do, and again, unless you're trained and you're kind of like licensed, due to liability reasons, you kind of want to teach your client to do it passively. So again, if there are no other questions, again, I want to thank you guys all so much. If you have any questions, like Eli had that question on taping, please let me know and I will forward you some great resources and videos that I trust on YouTube to learn how to do these tapings and manipulations. Okay, thank you guys so much, and we will see you for our June Thursday's webinar. Still thinking of the topics. So if you have any questions that you want us to do a webinar series on, please do not hesitate to email us as well. education@ebfafitness.com. Thank you guys and have an awesome night and a great weekend.